Everyone, I am Dr. Vipul. Today I'll be discussing something on neovascular glaucoma. Welcome to my channel first of all. Neovascular glaucoma is a secondary glaucoma resulting from neovascularization of the anterior segment including the iris and the angle, which is often associated with retinal ischemia. This is one of the most intractable types of secondary glaucoma, and if not recognized at an early stage, this can lead to rapid and profound visual loss, which can quickly progress to an absolute stage. In various hospital-based studies, the proportion of eyes with neovascular glaucoma among the secondary glaucomas was found to be 9 to 17.4%, although the overall prevalence rate is low. So these are some pictures of neovascularization of the iris and the angle structures. The first one, there is neovascularization of the iris at the pupillary area. The second one, there is neovascularization of iris on the iris surface. You can see these are branching tufts of vessels which can be seen on the iris surface. Third picture, the C picture, is a gonioscopic view of the angle of the anterior chamber where you can see the branching tufts of neovascular growth along the scleral spur and the trabecular meshwork. And the fourth picture, this is a severe stage of neovascularization of the iris where you can see ectropion uvea formation and there is surface iris neovascularization. These are another two pictures where you can see the pupillary area, there is neovascularization. Now this glaucoma is also called as rebotic glaucoma or hemorrhagic glaucoma or thrombotic glaucoma. Now a quick view on the history. Coates described these new vessels in a case of CRVO in 1906, and Weiss et al. Was the first to propose the term neovascular glaucoma in the year 1963, and the neovascularization of the iris was proposed by Walton and Grant. According to Duke Elder, it's a disastrous condition, severe and painful. The cornea is hazy and may become vascularized. The anterior chamber is typically of normal depth and may contain blood. The pupil is small and the iris trabeculae may show new vessels on its surface. The vitreous is often hazy and clouded by the red cells, and this precludes the view of the fundus, and the tension is very hard and all perception of light is lost. Any attempt at operative reduction of the ocular tension makes the matters worse by inducing profuse and recurrent hemorrhages, and only practical treatment if retrobulbar injection of alcohol or cyclodiathermy fails to relieve the pain is enucleation. Coming to the pathogenesis, what causes this neovascular glaucoma? In 97% of the cases, the causal factor is the retinal ischemia. 3% of the cases, it could be inflammation without retinal ischemia. So what happens? Ischemia leads to release of angiogenic and non-angiogenic factors which both inhibit and promote the new vessel growth. What are the prerequisites? There should be a viable retinal tissue. There should be low oxygen tension and the venous drainage should be intact, which allows accumulation of these factors. The inflammatory mediators such as angiopoietin 1 and angiopoietin 2 are now known to play a role in the vessel formation and their remodeling. Now, underlying etiology, what are the causes for this retinal ischemia and inflammation? 36% of the cases of all neovascular glaucoma arise from CRVO, 32% from proliferative diabetic retinopathy, 13% from carotid artery occlusive disease. Now, in some books, it has been mentioned that proliferative diabetic retinopathy is the most common cause, but in others, it is CRVO, ischemic CRVO. The other conditions which may lead to neovascular glaucoma includes BRVO, CRAO, tumors like choroidal melanoma. then chronic retinal detachment, retinopathy of prematurity, Coats retinopathy, severe uveitis, endophthalmitis, sickle cell retinopathy, radiation retinopathy, Eales disease, and persistent hyperplastic primary vitreous. Now, some view on CRVO, which is the commonest cause for the neovascular glaucoma. This is more common with ischemic CRVO. The overall incidence of NVI in CRVO cases is about 12 to 30%. The incidence of neovascular glaucoma ranges from 20 to 63%. Conventionally, it is termed as 100-day glaucoma and can occur say within 2 weeks to 2 years, typically around 3 months after initial occlusion of the vessel. Now, FFA is important to categorize between the ischemic and non-ischemic type of CRVO, and in case of indeterminate FFA, we should consider it as a ischemic type and follow up, because 1/3 of the cases of ischemic type convert to non-ischemic type convert to ischemic type. We should also consider pre-existing primary open angle glaucoma and angle closure glaucoma and examine other eye carefully, especially with a gonioscope. Now, diabetic retinopathy, what happens? There is retinal capillary non-perfusion which can be detected with FFA. ERG changes may be seen in the oscillatory potential of the B wave. The incidence of NVI in PDR is reported as high as 65%, with a 33% risk of contralateral eye developing NVG in people with diabetes with NVG in one eye. The cataract extraction and vitrectomy generally increases the risk of neovascularization because the PC and the anterior hyaloid becomes a relative barrier for crossing over of the crossing over of the angiogenic factors into the anterior chamber. Preoperative extent and severity of the diabetic retinopathy are more predictive of neovascular glaucoma. The third entity, that is carotid artery occlusive disease, this accounts for 13% of the cases. This may not be associated with elevated IOP because there will be decreased perfusion of the ciliary body, so less amount of aqueous production. Consider this entity if marked asymmetry is seen on diabetic retinopathy with no apparent cause for neovascular glaucoma. When you find asymmetry or absent carotid pulse, and Doppler studies are important to detect any carotid occlusion is there or not. And it has been seen that carotid endarterectomy may not be beneficial on all cases of this type of glaucoma. So these are the factors which are responsible for angiogenesis. The VEGF, that is vasculoendothelial growth factor, which is secreted by Muller cells, RPE, pericytes, ganglion cells, non-pigmented ciliary epithelium, the fibroblast growth factor, the insulin-like growth factor, derived growth factor, interleukin 6. So this is a flowchart of how it happens. The retinal hypoxia, this leads to the secretion of these pathogenic factors in high concentration, the VEGF and other factors. There are some anti-angiogenic factors which are also released like PEDF. So VEGF leads to increased vascular permeability, endothelial cell mitosis, leukocyte adhesion to the endothelial cells. Increased permeability leads to leaky vessels. Endothelial cell mitosis leads to new vessel formation, and the leukocyte adhesion to the endothelial cells, ultimately leading to breakdown of the blood retinal barrier, and the fibroblast proliferation is there. This leads to formation of fibrovascular membrane. The other things leads to neovascularization of the iris and neovascularization of the angles from minor and major arterial circle of the iris. Ultimately, all this leads to obstruction of the trabecular meshwork and leading to rise in the intraocular pressure and an open angle stage of glaucoma. Subsequently, there is contraction of this fibrovascular membrane leading to peripheral anterior synechial formation and an angle closure stage, which is the severe stage. Raised intraocular pressure is because of fibrovascular tissue over the trabecular meshwork. This decreases the flow of aqueous through the trabecular meshwork. There is increase in the number of myofibroblasts and there is endothelial cell proliferation. Now, symptoms in the early stage, there will be no symptoms which can be seen. Late symptoms are due to the raised intraocular pressure and its sequel. The signs in the early stage are NVI and NVA. In the late stage, you may find atropine UVA, pupillary reaction may be sluggish, RAPD may be seen, corneal stroma and epithelial edema will be there. Then visual acuity is grossly reduced and anterior segment flare may be seen. Now, these are the stages of neovascular glaucoma. It has been divided into 3 stages. Rebosis iridis, first stage. Second stage is secondary open angle glaucoma, and third is secondary angle closure glaucoma. In the rebosis iridis, what happens is tiny tufts of new vessels appear at first in the pupillary margin and less commonly at the angle, which cross the scleral spur to arborize over the trabecular meshwork. New vessel growth over the iris surface is in an irregular fashion. It is not in a radial fashion. The NVI may be present in this stage. Gonioscopy shows an open angle. NVA with or without NVI may be present. Intraocular pressure is normal in this stage and the prognosis is good in this stage. In the secondary open angle glaucoma stage, there is development of neovascular membrane on the anterior surface of the iris and the angle of the anterior chamber. This blocks the trabecular meshwork and obstructs the aqueous outflow. NVI may be prominent in this stage. The gonioscopy shows open angles. NVI may or may not be visible in this stage. IOP is raised, and if there is timely intervention, the prognosis is good. In the last stage, the secondary angle closure glaucoma stage, there is contraction of the fibrovascular membrane which pulls the iris over the trabecular meshwork, forming peripheral anterior synechiae. The neovascularization is prominent in this stage and ectropion UVA may be seen. Gonioscopy shows closed angles. NVA usually are not visible because of peripheral anterior synechiae formation. Intraocular pressure is raised and the prognosis is usually guarded. According to Weiss and Gold, uh, the various grades of iris neovascularization and neovascularization of the angle has been graded. These are graded into 4 grades. Grade 1 NVI, iris new vessels at the pupillary zone of less than 2 quadrant. Grade 2 is iris new vessels at the pupillary zone of more than 2 quadrants. Grade 3, iris new vessels at the ciliary zone and ectropion UVA of 1 to 3 quadrants. And grade 4, surface new vessels at the ciliary zone and or ectropion UVA of more than equal to 3 quadrants. And NVA grading, angle vessels cross the scleral spur and ramify on the trabecular meshwork of less than 2 quadrants. Grade 2, angle vessels cross the scleral spur and ramify on the trabecular meshwork of greater than 2 quadrants. Angle vessels at trabecular meshwork and peripheral anterior synechiae of 1 to 3 quadrants. And grade 4 is peripheral anterior synechiae of more than 3 quadrants. Now, early diagnosis, we have to have a high index of suspicion. Undilated pupillary examination under slit lamp with high magnification has to be done. Undilated gonioscopy has to be done. IOP measurement and dilated fundus examination to see for optic nerve head changes has to be done. Gonioscopy is a must in all cases. We have to see for angle neovascularization and peripheral anterior synechiae. This is a picture where you can see there is neovascularization of the angle and the angle structures, the trabecular meshwork, the scleral spur, and there is some peripheral anterior synechiae formation also on the right side. Now, what are the investigations we will do? Fundus fluorescent angiograph has to be done to assess for the retinal ischemia, which is the causative factor for neovascular glaucoma. OCT angiogram can be done. This is a new technique where non-invasive imaging is done based on motion contrast. This, in comparison to FFA, can delineate the extent and the depth of the neovascularization, and this is an excellent tool for follow-up to document regression of the neovascularization. Other modalities which are used for detection include ERG to assess the retinal ischemia. This measures the mass electrical response of the retina, allowing the assessment of the retinal periphery, which cannot be seen with fluorescent angiography. Another thing which can be detected from ERG is whether ischemic CRVO lead to neovascular glaucoma or not. The B wave to A wave amplitude ratio of the bright flash and dark adapted ERG is helpful. If it is less than 1, it shows that there is more chances of development of neovascular glaucoma after ischemic CRVO. In contrast, if the ratio is greater than 1, then this eyes may not develop NVG following an ischemic CRVO. These are some photographs. First one is a fundus photograph where you can see a neovascularization of the disc, the peripapillary area you can see with the marked arrow. The second picture, the B picture, you can see a fundus fluorescent angiogram where you can see the leaky neovascular growth. The leakage is there in the peripapillary region. The C and D are OCT angiogram pictures. You can see on the C picture the extent and the depth of the neovascular growth in the peripapillary area, which in the D picture, this is a picture taken after an intravitreal injection of anti-VEGF, where you can see the regression which is clearly visible. On the E picture, this is a wide field view of the OCT angiogram where the star mark areas you can see, these are areas of capillary non-perfusion. Then other modalities which are helpful in detection are quantitative laser photometry. This aids in the detection of subclinical flare events with iris fluorescent angiogram. This aids in detection of occult neovascularization. The iris fluorescent angiogram can be done, and SLO can be used in cases of doubtful NVI. B-scan ultrasound is helpful where the retina is not visible due to media opacity or corneal edema to detect any intraocular tumors or chronic retinal detachment or tractional RD or vitreous hemorrhage. Systemic investigations including fasting blood sugar and PPBS to rule out diabetic retinopathy, diabetes mellitus, and carotid Doppler in case of ocular ischemic syndrome, where there is absence of PDR and CRVO. This is a laser flare photometry of a patient being done. These are some graphs which you can see in the first graph. There is peaked amplitude where there is flare. The second graph is a normal eye where there is no peaking of the graph amplitude. And these are some pictures of fluorescent angiography of the iris. Uh, first, first picture, infrared image and a scanning laser ophthalmoscope image. The second, the down picture, the downward pictures are of OCT angiogram. This first four pictures are a normal eye. The second one you can see A and C, normal image with a magnified image where you can see neovascularization in the pupillary area, and B and D are pictures taken after anti-VEGF injection. So there is regression of the neovascularization of the iris at the pupillary area. Now, what are the differential diagnoses which should be considered? Like uveitic glaucoma, there will be intense inflammation of the anterior chamber, flare cells with KPs, which may not be visible in case of neovascular glaucoma. Then acute angle closure glaucoma and chronic angle closure glaucoma should be detected. Gonioscopy has to be done to see for peripheral anterior synecdoche formation and occludable angles. Then iridocorneal endothelial syndrome. This is an entity where it should be differentiated from neovascular glaucoma. Here you will find iris atrophy with correctopia and polychoria, which may not be visible with neovascularization of the iris. Neovascular glaucoma. Fuchs heterochromic iridocycleritis should be differentiated. Here you will find heterochromia of the iris, which may not be seen in neovascular glaucoma, and neovascularization will not be detected in Fuchs heterochromic iridocyclitis. Now this is the management protocol of neovascular glaucoma. So neovascularization of the iris or neovascularization of the angle structures with a higher IOP where there is no PL and no pain, we have to just observe, and if there is a pain which is there, painful blind eye, we start topical cycloplegics and steroids, and if it is persistent, the pain is persistent, then we go for enucleation evisceration or transscleral cyclophotocoagulation. And when there is a high IOP, the vision is PL or better and the media is clear, we have to treat three things: control the IOP, treat the etiology, and treat any inflammation. So control of IOP by medical therapy, anti-glaucoma medications, beta blockers, alpha agonists, or carbonic anhydrase inhibitors, topical, has to be used. IOP, if it is still high, then we have to go for surgical intervention like trabeculectomy, glaucoma drainage device, or transscleral cyclophotocoagulation. We have to treat the etiology, which is ischemia, by intravitreal anti-VEGF injections and PRP within 1 week, and then a follow-up after a week. And any inflammation should be treated with cycloplegics and steroids. Now, the vision is PL or better and the media is not clear. This could be either due to corneal edema, due to cataract formation, or due to vitreous hemorrhage or tractional RD. If it is due to corneal edema, medical control of the intraocular pressure with intravitreal injection of anti-VEGF agents and anti-retinal cryotherapy may be useful. If it is clear, then we go for a PRP plus we have to control the intraocular pressure. If the corneal edema doesn't clear, then we go for a glaucoma filtration surgery followed by a PRP within say 1 to 3 days post-operative. Many surgeons, they take at least 4 weeks for the PRP to be done. Then if the cataract is there, we have to control the IOP first. Intravitreal injection of anti-VEGF agents has to be used, and if still not under control, we can use anti-retinal cryotherapy. Then we go for a cataract extraction, and later on PRP is done, say 1 to 3 days post-operatively with control of intraocular pressure. And if it is a vitreous hemorrhage or TRD, we have to medically control the intraocular pressure, intravitreal injection of anti-VEGF agents and anti-retinal cryotherapy, and later on early vitreoretinal surgery within 1 week, and then control of intraocular pressure. And if suppose NVA with a normal IOP is there, we have to manage similarly except for IOP management. So what are in details, what are the treatments of the underlying process? We have to do a PRP, pan-retinal photocoagulation, either with the slit lamp argon laser or with a laser indirect ophthalmoscope or endolaser. Then other modalities of treating are anti-retinal cryotherapy. Anti-retinal cryotherapy is an alternative to PRP or as an augmentation of PRP in eyes that have cloudy media and in eyes for which complete PRP fails to halt the progression of neovascularization. Then gonio-photocoagulation is another modality which may be used as an adjunct to PRP to reduce the neovascularization in the angle before it is closed by synechia, but generally the effects are only temporary in these cases. Then we have other modalities like micropulse transcleral cyclophotocoagulation. This can be used in seeing eyes with good visual potential. Various studies have shown the regression of neovascularization in 68% of the cases and normalization of the IOP in 42% of the cases. In another study, it has been found to have a success rate of 73.7%. Now, treatment of the raised IOP by surgical means. Before any glaucoma surgery is attempted, we should reduce and eliminate the stimulus for angiogenesis using PRP and other modalities which has been mentioned. In eyes with vision better than 20/400, most glaucoma specialists prefer to go for glaucoma drainage implant placement or filtration surgery versus micropulse transcleral cyclophotocoagulation. Now, trabeculectomy with antimetabolites has a success rate of 61 to 67%. Aqueous shunt devices has a success rate of 56 to 62%. In various studies, they have been found. Now, cyclodestruction is attempted in eyes with visual potential of 20/400 or worse. Here we can use endoscopic cyclophotocoagulation with power range of 100 to 300 milliwatt or transcleral diode laser cyclophotocoagulation. And in painful blind eye with very poor visual potential, we can go for cyclocryotherapy, retrobulbar injection of alcohol, and enucleation to achieve comfort. These are some two of the photographs of endoscopic cyclophotocoagulation. This is first one is an anterior approach through the cornea underneath the pupil, and the second one is a posterior approach through the pars plana, where you directly cyclophotocoagulate the ciliary processes. Now, treatment of raised IOP if the eye has no visual potential. Medical treatment with aqueous suppressants, beta blockers, carbonic anhydrase inhibitors, and alpha agonists. Topical we can use. We have to avoid pilocarpine, dapivirine, and prostaglandin analogs because they might cause inflammation. Topical atropine can be used, and topical steroids, predacetate, can be used. Once the anterior chamber angle is closed, medical therapy is of no use alone, and we have to go for surgical intervention. There are high failure rates in all methods. Cyclodestruction is associated with high incidence of hypotony, thysis bulbi, postoperative pain, intraocular hemorrhage, choroidal detachment, uveitis, and loss of best-corrected visual acuity. Now, adjuvant treatments like anti-VEGF agents, intravitreal triamcinolone, these generally provides a window for the definitive treatment and makes surgery easier. They are not sufficient alone for the management of this condition, and as anti-VEGF injections are becoming standard care for patients presenting with neovascular glaucoma and have improved the visual outcomes and comfort when combined with PRP or cyclophotocoagulation or prior to performing incisional surgeries like trabeculectomy, glaucoma drainage device implantation. Thank you everyone. If you like my videos, please give a like and subscribe.